A 55-year-old male presents with shoulder and arm pain. I am showing you his frontal chest radiograph and a cone-down view of the right lung apex. Describe the findings.
The frontal chest radiograph demonstrates a large, dense, soft tissue mass in the right lung apex. The cone-down view of the right lung apex confirms the mass and demonstrates associated cortical destruction of the posterior portion of the second rib, indicating chest wall invasion. These findings are highly characteristic of a superior sulcus tumor.
Based on these imaging findings, what is your primary diagnosis and the anatomical name of this tumor?
The primary diagnosis is an apical bronchogenic carcinoma, anatomically referred to as a superior sulcus tumor or Pancoast tumor.
If I tell you the patient has a heavy smoking history and presents with drooping of the upper eyelid and a constricted pupil on the same side, how does this clinical history affect your diagnosis?
This clinical history confirms Pancoast syndrome. The drooping eyelid and constricted pupil represent ptosis and meiosis, which are components of Horner's syndrome caused by tumor invasion of the sympathetic chain or stellate ganglion. The heavy smoking history makes squamous cell carcinoma or adenocarcinoma the most likely histology.
Does the presence of chest wall invasion, as indicated by the rib destruction, preclude surgical resection?
No, chest wall invasion alone does not preclude resection. These patients are typically managed with neoadjuvant chemotherapy and radiation therapy, followed by en-bloc surgical resection of the lobe and the involved chest wall.
Why is MRI the imaging modality of choice to determine resectability of superior sulcus tumors compared to CT?
MRI is far superior for demonstrating soft tissue contrast, allowing precise evaluation of tumor extension into the brachial plexus, neural foramina, vertebral bodies, and subclavian vessels, which determines whether the tumor can be surgically resected.
List 4 absolute contraindications to surgical resection of a superior sulcus tumor.
The absolute contraindications are: first, brachial plexus invasion above the T1 nerve root level; second, invasion of more than 50% of a vertebral body; third, invasion of the trachea or esophagus; and fourth, encasement of the subclavian artery.
What are the 3 clinical components of Pancoast syndrome?
The components are shoulder and arm pain radiating down the C8T2 dermatomes, Horner's syndrome, and weakness and atrophy of the intrinsic muscles of the hand due to T1 nerve root involvement.
Explain the clinical triad of Horner's syndrome.
Horner's syndrome consists of ipsilateral ptosis, meiosis, and anhidrosis, which is a loss of sweating, resulting from disruption of the sympathetic pathway.
What is the role of PET-CT in the staging of these tumors?
PET-CT is used for systemic staging to detect mediastinal lung node metastases and distant hematogenous metastases, which would also preclude local surgical resection.
State the critical safety warnings and immediate management recommendations if a patient presents with progressive leg weakness.
The critical safety warning is acute spinal cord compression from tumor extension through the neural foramina. If the patient develops progressive lower extremity weakness or sphincter dysfunction, it is a neurosurgical emergency. The radiologist must advise immediate high-dose intravenous dexamethasone, order an urgent spinal MRI, and refer to neurosurgery and thoracic oncology.